Safely executing a cholecystectomy begins with precise patient stratification. Surgical intervention requires a rigorous clinical history, a full lab panel evaluating liver function and prothrombin time, and informed consent that explicitly addresses the risk of complications. During anesthesia induction, prophylactic measures are mandatory. Surgeons must administer second-generation cephalosporins and ensure active deep vein thrombosis prophylaxis is in place. Identifying the specific variables that predict a difficult procedure allows for better operative planning. Male patients over 65, clinical presentations delayed beyond 72 hours, and gallbladder wall thickening over 4 millimeters indicate an elevated risk. Additional intraoperative flags include contracted or gangrenous gallbladder states and Marizzi syndrome, increasing the likelihood of converted procedures. Clinical parameters also stratify the risk of common bile duct stones. Probabilities fall into 3 tiers: low, 2 to 3%, medium, 20 to 40%, and high risk, 50 to 80%. High-risk thresholds include clinical jaundice or an ultrasound showing a common bile duct diameter over 10 millimeters, mandating preoperative evaluation via MRCP or ERCP. Rigorous preoperative risk stratification serves as the initial defense against intraoperative morbidity. By mapping these variables before the first incision, surgeons can better anticipate and manage anatomical challenges. Optimizing spatial orientation requires precise patient positioning. The patient is placed supine in a reverse Trendelenburg position with a slight left rotation to facilitate gravity-assisted retraction of the viscera. Establishing pneumoperitoneum can be achieved through several mechanics. Many surgeons utilize a closed Vera's needle technique, while others prefer an open subumbilical cut-down for direct visualization when placing the initial port for the 30-degree telescope. While single-port laparoscopic cholecystectomy is available, clinical data indicates limitations. Systematic reviews note higher failure rates and increased blood loss compared to traditional multi-port techniques. Standard port configuration involves additional working ports in the subxiphoid and right subcostal areas. This triangulated placement provides the necessary angles for safe dissection and manipulation. Disciplined entry mechanics and port placement establish the foundational geometry required to maintain safe spatial orientation throughout a highly variable abdominal environment. Effective exposure depends on exact retraction mechanics. The fundus is retracted toward the right shoulder, and the infundibulum inferolaterally. This tension opens the hepatocystic triangle, increasing the angle between the cystic and common bile duct for clear identification. Surgeons map the safe zone of dissection using the R4U line, extending from Rouvier's sulcus to the umbilical fissure. All safe dissection must remain cephalad to this boundary. Dissecting below it increases the risk of encountering major bile ducts and central vascular structures. The B-Safe framework provides a cognitive map: the bile duct, sulcus of Rouvier, the hepatic artery, the umbilical fissure, and enteric structures. Strict cognitive adherence to the R4U boundary and B-Safe landmarks provides the surgeon with a reliable mental map to navigate, away from anatomical danger zones, even when severe inflammation distorts the local tissue. Dissection aims for one conclusive goal: the critical view of safety. This view ensures definitive identification of the cystic duct and cystic artery to prevent misidentification injuries. The first step in achieving this view is the complete clearance of all fibrofatty and soft areolar tissue from the hepatocystic triangle. The surgeon must confirm that only 2 structures, the cystic duct and cystic artery, enter the gallbladder before proceeding. The second step is separating the gallbladder from its liver bed to expose at least the medial third of the cystic plate. Energy application during this process must be disciplined. Using monopolar energy requires low settings, approximately 30 watts, with short intermittent bursts and gentle tissue tension to avoid thermal injury to deeper structures. Establishing the critical view of safety is a definitive requirement that must be satisfied prior to any structural clipping or division. Specific red flag signs demand that dissections stop immediately. These include severe adhesions, acute inflammation, large stones impacted in the gallbladder neck, or Marizzi syndrome. If anatomical disorientation occurs, the team must call a timeout. This protocol involves stopping the dissection and seeking a second opinion to ensure patient safety. If the critical view of safety cannot be achieved, the surgeon pivots to a bailout strategy. This may involve aborting the procedure entirely or making the early choice to convert to an open laparotomy. Open conversion is performed using a Kocher subcostal or upper midline incision. This allows for direct packing of the hepatic flexure and duodenum to clarify the anatomy of the porta hepatis. Other bailout options include placing a 14 French Foley catheter for a tube cholecystostomy, performing a subtotal cholecystectomy that leaves the cystic plate attached, or utilizing a fundus-first approach. Deploying a bailout strategy reflects advanced surgical judgment. It ensures patient safety remains the primary objective, even when the intended procedural completion is not possible. Despite technical safeguards, complications occur in 10 to 15% of cases. Laparoscopic cholecystectomy carries a 0.5% incidence of bile duct injuries, usually resulting from inadequate anatomical definition. Postoperative jaundice, fever, or abdominal pain mandates an urgent investigation. The first step is an ultrasound to assess for intrahepatic or extrahepatic ductal dilatation. The Strasberg system classifies these injuries based on their anatomical location and severity, ranging from cystic duct leaks in type A to complete extrahepatic duct excision in type E6. A cystic duct stump leak, classified as type A, is the most common biliary injury. These are typically managed via ERCP, with the placement of a biliary stent to bridge the leak. Severe strictures or complete duct transections, categorized as type E injuries, require surgical repair. The standard treatment is a Roux-en-Y hepaticojejunostomy performed by a specialist hepatobiliary surgeon. Recovery depends on the immediate recognition of failure and the rapid deployment of a multidisciplinary diagnostic and surgical salvage algorithm. Retained duct stones can present years after the initial surgery. Symptomatic patients often exhibit Charcot's triad: episodic pain, jaundice, and fever. The first-line intervention for stone extraction is an ERCP. A sphincterotomy is performed at the ampulla to allow for the removal of the stones. Radiographic imaging of an obstructed duct reveals multiple radiolucent filling defects within the dilated common bile duct, indicating the presence of retained stones. If endoscopic methods fail, an open colodicotomy is necessary. The stones are cleared through a longitudinal incision in the duct, and a T-tube is inserted to provide external drainage while the duct heals. After the T-tube tract has matured for 6 weeks, the percutaneous Berheni technique can be employed. This involves using a steerable catheter and basket to extract any remaining stones via the established tract. Managing retained stones requires a stepwise escalation from endoscopic relief to radiological extraction to prevent the progression of suppurative cholangitis. Some biliary conditions mimic surgical complications but result from intrinsic pathology. Primary sclerosing cholangitis, or PSC, is a progressive disease that causes inflammation and destruction of the bile ducts, eventually leading to cirrhosis. PSC is most common in men between 30 and 60 and has an 80% association with ulcerative colitis. Laboratory tests typically show a cholestatic pattern with elevated alkaline phosphatase and GGTP. Radiographic diagnosis relies on identifying stricturing and beading of the bile ducts, often visualized during an ERCP or MRCP. This radiographic beading reflects the underlying histology, concentric periductal onion skinning fibrosis, that is characteristic of the disease. PSC must be differentiated from IgG4-related cholangitis. While both cause biliary narrowing, IgG4-related cases often involve elevated serum IgG4 levels and respond well to systemic steroid therapy. Managing the biliary system relies on a combination of technical operative skill and the clinical vigilance to identify systemic pathologies.